podcast's own channel. So today we're doing a deep dive into the absolute gold standard of surgical knowledge. We're looking specifically at breast cancer. And I gotta say, right off the bat, the biggest shock we found in our sources today.
Oh, yeah, the terminology thing.
Yeah. We're actually going to explain why one of the most terrifying, carcinomas a patient can be diagnosed with, well, isn't actually cancer at all. So grab your coffee. You are definitely in the right place.
It's a massive misconception, honestly. And I mean, it really speaks to how much our understanding of this entire disease is constantly shifting.
Right.
And just to set the stage for you listening, we're pulling all of our information today directly from the Bailey and Love Short Practice last edition.
Mm-hmm.
We're focusing pretty heavily on their chapters detailing the epidemiology, the pathology, and, the surgical management.
Which is fascinating because, I always thought of this as a purely structural problem, right? Like you find a lump, a surgeon goes in, they just cut it out.
Yeah, the classic plumbing approach.
Exactly. But reading through the Bailey and the Love text, it paints a picture of a medical field that has largely moved way past the scalpel as their only weapon.
Absolutely. I mean, the historical approach really was just anatomical. You cut out the tumor, you cut out the surrounding tissue, and you just, hope you got it all.
And crossed your fingers.
Right. But today, we are in this incredible era of personalized molecular science. So we don't just look at the physical size of the tumor anymore. We actively decode its specific genetic fingerprint.
Wow.
Yeah. And before we even consider surgery in a lot of cases, we often try to reprogram the environment that the tumor actually lives in.
Okay, so to understand that genetic fingerprint, we kind of have to understand what causes those genetic typos in the first place, right?
Yes, exactly.
And the Bailey and Love text points to this thing called the estrogen exposure rule, which basically dictates the overarching biological driver of the whole disease.
Yeah, so think of estrogen as the engine.
Yeah.
Its primary job in breast tissue is, well, to stimulate cell division. And every single time a cell divides, it has to copy its entire DNA sequence. So the more times those cells are forced to divide over a woman's lifetime, the higher the mathematical probability that, a microscopic copying error is going to happen.
Right, it's just a numbers game.
Exactly.
Yep.
And that single uncorrected typo is what actually initiates the cancer.
I picture it kind of like sun exposure on your skin.
Oh, that's a good analogy.
Yeah, like a single afternoon at the beach isn't going to suddenly give you melanoma, right? But every single year of UV exposure, it all adds up.
Right.
So with breast tissue, every year of estrogen cycling just sort of ticks that biological clock forward. And that completely explains the risk factors tied to a woman's menstrual timeline, right?
It does, yeah.
Like if a girl starts her first period early, say, before age 12, and then hits menopause late, like after 55, she has a significantly wider lifetime window of that estrogen exposure.
And the math on that is actually quite rigid. The risk increases by 3 to 5% for every single year of deviation outside that normal window.
Wow, every year.
Yeah. And of course, a patient has zero control over their menstrual timeline.
Yeah.
Just like, they have absolutely no control over their family history.
Which, bringing up family history, that brings up a really crucial distinction the text makes about risk. Because reading the statistics, initially it felt like wading through this abstract math problem. But when you put the numbers side by side, it's actually terrifying.
Oh, the relative risk numbers.
Yeah. Like having one first-degree relative with the disease, that doubles your risk.
Yeah.
But then the text brings up this biopsy finding called LCIS, lobular carcinoma in situ. And if a patient has that, their risk isn't just doubled. It's multiplied by 8 to 10.
Yeah, LCIS is essentially the loudest alarm bell the body can possibly ring before invasive cancer actually strikes.
8 to 10 times is wild.
It is. It tells us the tissue is just incredibly unstable.
Mm-hmm.
And, we also have to factor in hereditary genetics, which make up about 5 to 10% of all cases.
And that's the BRCA mutations.
Exactly. Within that small genetic slice, BRCA1 and BRCA2 mutations are the dominant culprits. They make up 70% of those specific hereditary cases.
Okay, so we obviously can't edit our genetics yet, but the text does highlight modifiable risks too, like obesity, specifically a BMI over 30, which increases the risk for postmenopausal women.
Yep, because fat tissue actually produces estrogen after menopause.
Oh, wow, okay, that makes sense. And then heavy alcohol use, which the text defines as more than 4 drinks a day, that spikes the risk by nearly 50%.
Yeah, significant.
And prior radiation to the chest is a massive danger. But then conversely, breastfeeding for more than a year is highly protective.
Right, because it functionally hits the pause button on that estrogen cycling. It all circles back to pausing or accelerating that estrogen engine.
Right, the sun exposure analogy again.
Exactly. But to truly grasp the danger, we really have to look at the global epidemiology, what we call the geography of survival.
Lay it on me.
So breast cancer accounts for a quarter of all female cancers worldwide, 25%. In Western nations, the incidence is exceptionally high. Like 1 in 9 women will develop it, usually around a median age of 60.
Okay.
But because of really robust screening programs, the survival rates in the West are actually quite high.
But the inverse is true in resource-poor nations, right? The incidence is technically lower, like 1 in 28 women, but the mortality is absolutely devastating.
It is. A staggering 50% of those diagnosed will die.
50%. And the median age drops drastically, too, down to 48. It just makes you realize that survival isn't just about the biology of the tumor. It's about when you actually catch that typo.
Precisely. It's all about early detection. And so
Yeah.
when that genetic typo happens and the cancer initiates, we have to classify what we're actually dealing with.
Right.
About 90% of the time, the tumor originates in the ducts, which are the tubes that carry milk. And then 10% of the time, it starts in the lobules, the glands where the milk is actually produced.
But just knowing where it started doesn't really tell a surgeon how dangerous it is, right?
No, not at all.
And that is where the Bloom-Richardson scoring system comes in. Because when I read how pathologists grade these tumors, I gotta be honest, it felt less like medicine and more like building a criminal profile for a cell.
Haha. That is actually a highly accurate way to frame it. I like that.
Okay.
The pathologist is looking at the cells under a microscope and evaluating 3 distinct, criminal traits, scoring each from 1 to 3.
Okay, what's the first one?
The first trait is tubule formation. Normal breast cells form really neat, organized tubes. So the pathologist asks, has this cell completely forgotten how to build normal architecture?
Okay, so a loss of normal function. And the second trait is nuclear pleomorphism, which sounds incredibly dense.
It's a mouthful, yeah.
Right? But it basically just means looking at the nucleus, like the brain of the cell, and asking, how deranged does this look?
Exactly. Pleomorphism literally translates to variation in size and shape. Normal, healthy nuclei, they look uniform and quiet. Aggressive cancer nuclei look angry, chaotic, and just wildly irregular.
And the third one?
The third trait is the mitotic count, which is simply a measure of how fast the cells are actively dividing. So if a tumor scores an 8 or 9 out of the 9 total points, we classify it as grade 3.
Which is bad.
Very bad. It's poorly differentiated, meaning it looks absolutely nothing like normal tissue, and it is highly aggressive.
So we know how angry the cell looks from that criminal profile, but the Bailey love text emphasizes that visual grading just isn't enough anymore.
No, it's not.
Like, surgeons realized they couldn't just guess a tumor's vulnerability based on its size or shape. They had to understand its actual supply lines.
Yes, and this is the molecular paradigm shift I mentioned earlier. We now categorize tumors into 4 main molecular subtypes by looking at the receptors on the surface of the cell. The antenna. All right, think of these receptors like cellular antennas. They stick out of the cancer cell and they pull in signals from the bloodstream, basically telling the cell to grow.
Okay, so the first subtype is liminal A, and these cells have antennas for estrogen and progesterone, but they are negative for a protein called ATR2.
Correct.
They also have a low Chi-67 score, which, from what I read, is just a marker showing they divide pretty slowly.
Yeah, exactly. And because they rely so heavily on hormone signals to grow, we can actually jam those signals pretty easily.
Sure.
That makes luminal A the most treatable subtype.
Okay, so it's liminal B.
Luminal B also has those hormone antennas, but it has a much higher Chi-67 score, so it's dividing a lot more aggressively.
Got it.
Then we have the third subtype, which is HER2 enriched. These lack the hormone antennas entirely, but they drastically overexpress that HER2 protein on their surface. Historically, these were lethal because we couldn't starve them of estrogen.
But then modern medicine engineered a drug called trastuzumab, right?
Yes, exactly.
Which basically acts like a heat-seeking missile.
That's a perfect description. Trastuzumab specifically hunts down those HER2 antennas, binds to them, and just destroys the cell without harming the surrounding normal tissue.
That is incredible. But the fourth subtype is the one that really seems to, keep oncologists up at night. The basal or triple negative.
Yeah, triple negative is tough.
Because it has no estrogen antennas, no progesterone antennas, and no HER2 antennas. So it is completely invisible to all of our targeted therapies.
Yep. It divides incredibly fast, And it is the most common type found in patients with those BRCA1 mutations we talked about. We essentially have to rely on broad-spectrum, traditional chemotherapy to fight it.
Man. Okay, so knowing the molecular subtype tells us how to treat the tumor. But we still have to understand how the tumor physically manipulates the patient's body, right? Because tumors aren't just passive lumps of tissue, they are hostile invaders that actively terraform their environment.
Oh, absolutely. And that terraforming process is called the desmoplastic reaction. The mechanism behind it is truly fascinating. The tumor needs resources, right? So it releases chemical growth factors into the surrounding breast tissue. Things like FGF, TGF, and VEGF.
And VEGF is the critical one there, right? Vascular endothelial growth factor.
Exactly.
The cancer cell essentially broadcasts this fake physiological distress signal, tricking the patient's own body into building a brand new highway of blood vessels directly to the tumor.
It builds its own supply line. And while it's doing that, those other growth factors hijack normal structural cells in the breast, turning them into this dense, hard collagen.
Wow.
Yeah, the tumor essentially builds a fibrous fortress around itself. And as that fortress contracts, it pulls on the Cooper's ligaments, which are the natural suspensory bands in the breast.
Oh, okay. And that pulling is what causes the visible skin dimpling that patients often notice first.
Exactly. Or, the fortress contracts around the major milk ducts, causing the nipple to invert or retract. There's also a severe clinical sign called peau d'orange, which translates to orange peel.
Yes, I was reading about that. The tumor physically blocks the lymphatic drainage vessels just beneath the skin, right?
Yeah.
So the breast swells up with all this trapped fluid, but the little hair follicles remain tightly anchored down. So the skin literally bulges out around the follicles, making the breast look identically dimpled to an orange peel.
It's a very distinct, very concerning sign. And in the most extreme neglected cases, the tumor can actually infiltrate the skin of the chest wall so extensively that it forms this hard, restrictive plaque. Historically, this was termed cancer en cuirasse, which basically means a breastplate of armor.
That sounds horrific, but the ultimate threat isn't the local fortress, right? It's when the tumor breaches the walls and escapes.
Right, metastasis. The Bailey and Love text notes that cancer usually travels first through the lymphatic system to the axilla, so the armpit nodes on the same side.
But there is a geographical trick here, right? Because if the tumor is located on the inner half of the breast, near the sternum, it often completely bypasses the armpit and drains deep into the internal mammary nodes hidden behind the ribs.
Exactly. And once those new blood vessels we talked about, the VEGF ones, are fully established, the cancer can spread hematogenously, meaning directly through the bloodstream, and it has a very high biological affinity for bone tissue.
Specifically, the lumbar vertebrae in the lower back and the neck of the femur in the leg.
Yes.
And the text describes this terrifying scenario where the cancer infiltrates the bone marrow so aggressively that it physically crowds out the space where blood is made.
Yeah, the marrow gets completely overtaken.
And that forces the body to just eject immature, half-formed red and white blood cells into the bloodstream, which is a condition called leukoerythroblastic anemia.
Which is exactly why staging is so critical. We used to rely entirely on the TNM system, tumor size, node involvement, and metastasis, just pure physical anatomy. But the AJCC 8th edition staging manual completely rewrote the rulebook to incorporate the biology.
And this is the part that completely rewired my understanding of the terminology. Under this new staging edition, LCIS, lobular carcinoma in situ, is officially no longer classified as cancer.
Yep.
Which is crazy because it has the word carcinoma right there in the acronym. For a patient hearing that, the terminology is an absolute nightmare. How can it not be cancer?
I know. The medical community actually debated renaming it entirely because of the panic it causes. But this shift perfectly highlights evidence-based medicine correcting itself.
Okay, how so?
Well, researchers tracked decades of data and realized that while LCIS means the tissue is highly unstable, and yes, the patient is at extreme risk of developing cancer later, the LCIS cells themselves do not have the biological machinery to invade surrounding tissue. They don't behave like a true malignancy. So, to prevent surgeons from unnecessarily amputating breasts, the international community just downgraded it to a high-risk benign lesion.
It is incredible how the definition of cancer literally changes as our microscopes get better. But, okay, let's say the tumor is actually invasive, it is staged, and it's time for the surgeon to intervene. Logic tells you the first step is to just cut it out.
Right.
But according to the text, for many patients, the surgeon doesn't even touch a scalpel initially.
No, they don't. We frequently start with neoadjuvant systemic therapy, or NACT. That means giving the chemotherapy or the targeted drugs before any surgery happens.
Why do it in that order?
We do this to downsize the tumor. The hope is to shrink a massive mass, enough that the patient can avoid a full mastectomy and just have a lumpectomy instead.
It also gives the oncologist a real-time in vivo testing ground, right? Because if you cut the tumor out first and then give chemo, you're basically just blindly hoping the invisible remaining cells react to the drug.
Exactly. But if you leave the tumor in the breast and give the chemo, you can watch it on an ultrasound. You can see with your own eyes if the drug is actually killing the tumor.
And we measure that success with the RECIST criteria, which I have to admit sounds like a bad 80s band.
It kind of does. But it's critical. If the tumor shrinks by at least 30%, we call that a partial response.
Okay.
But if the patient has progressive disease, meaning the tumor actually grows by 20% or more despite the chemotherapy, that induces a clinical panic. It tells the oncologist instantly that the tumor is immune to the current regimen, and they must switch drugs immediately to save the patient's life.
Obviously, the ultimate goal is a complete response, where the drugs completely melt the tumor away to nothing. But that actually creates a massive logistical headache for the surgeon.
It really does.
Because if the chemo works perfectly and the tumor vanishes from the imaging, the surgeon still has to go in and remove the tissue bed where the tumor used to be, just to ensure no microscopic cells survived. But how do you cut out something you can no longer see?
That is the paradox of a perfect response. And to solve it, radiologists now intervene before the chemo even starts. They insert a tiny radio-opaque clip or a magnetic seed, like a mag seed, directly into the center of the tumor.
That is so smart.
Right. So weeks later, when the tumor is gone, the surgeon uses a magnetic probe in the operating room to hunt down that exact seed, ensuring they remove the precise patch of tissue.
And the goal of that surgery, whether it's a lumpectomy or a full mastectomy, is always achieving negative margins.
Always. The pathologist covers the outside of the removed tissue with colored ink. And if they look under the microscope and see cancer cells physically touching that ink, it means the surgeon cut directly through the tumor, leaving cancer behind in the patient.
Yikes.
Yeah. For invasive cancer, we just need a clear boundary. But for non-invasive DCIS, we demand a strict 2 millimeter safe buffer.
And the text makes a really strict rule regarding lumpectomies, or breast conservation surgery. It must always be paired with radiotherapy to sterilize the remaining breast tissue. Like, it's an absolute package deal.
It is. Which means if a patient have a condition like lupus or scleroderma, where their immune system attacks their own connective tissue, radiotherapy will cause catastrophic scarring to their chest.
Oh, wow, I didn't even think about that.
Yeah, or if they have severe pulmonary disease, physically cannot lie flat on the radiation table for 20 minutes, breast conservation is completely off the table. They must have a mastectomy.
And while addressing the breast, the surgeon also has to manage the axilla, right? The lymph nodes in the armpit. Because the presence of cancer in those nodes is the single most important predictor of whether the patient will survive long-term.
Historically, surgeons performed what's called an axillary lymph node dissection, essentially stripping out every single lymph node they could possibly find. The morbidity was terrible. Women were left with permanent, painful swelling in their arms called lymphedema, and surgeons risked slicing major nerves.
Like the long thoracic nerve. Because if you sever that, the patient loses control of their shoulder blade, resulting in a winged scapula. You also have the thoracodorsal nerve and the intercostobrachial nerve, which provides sensation to the inner arm.
Exactly. So to avoid that devastation, the modern standard is the Sentinel lymph node biopsy.
How does that work?
We inject a radioactive technetium tracer, or a blue dye, into the breast. We then watch to see which single lymph node in the armpit absorbs the dye first. That is the Sentinel guard node.
Oh, clever.
Right, so we remove just that one node. If it is clear of cancer, we know the cancer hasn't spread, and we leave the rest of the armpit perfectly intact.
It is such an elegant solution. And for the patients who do lose their breast to a mastectomy, the reconstructive options have evolved beautifully too. The Bailey Love text highlights the DIEP flap as the gold standard.
Yes, the DIEP flap is remarkable.
Surgeons harvest skin and fat from the lower abdomen, and they meticulously reconnect the tiny blood vessels in the chest to rebuild the breast. But crucially, they leave the patient's abdominal muscles completely intact.
Implants are also an option, of course, but there's a biological caveat. If the patient requires radiotherapy after an implant is placed, the radiation fries the tissue around the implant. It causes it to contract and harden into a painful sphere, which is a complication known as capsular contracture.
Ouch. Okay, so the surgery is complete. The physical mass is sitting in a pathology jar. But the patient isn't cured yet because the medical team has to assume there are invisible micrometastases floating in the bloodstream. This is the mop-up phase, right? Adjuvant therapy.
Yes. Depending on those molecular antennas we discussed earlier, we might use anthracycline or taxane-based chemotherapy to carpet bomb the remaining cells. Or we use trastuzumab for the HER2 positive tumors.
But for the hormone-positive tumors, the mop-up phase relies on endocrine therapy to starve the microscopic cells. For premenopausal women, that's tamoxifen. But for postmenopausal women, the text highlights drugs called aromatase inhibitors, like letrozole. And here is the cascade effect of medicine, right? Letrozole is so incredibly effective at stripping every last drop of estrogen out of the body that it rapidly accelerates bone density loss.
It does. Patients on these drugs absolutely must get regular DEXA scans, or they will develop severe osteoporosis. You fix one problem, you have to diligently manage the side effects of the cure.
Right. But if you're listening to this and assuming that more treatment, specifically more chemotherapy, is always safer, the introduction of genomic tools like Oncotype DX proves the exact opposite.
Yes, the Oncotype test is a game changer. It looks at 21 specific genes within an estrogen-positive tumor to predict how likely it is to recur.
And if the score comes back extremely low, the data proves that putting the patient through months of toxic chemotherapy will provide zero added survival benefit, none.
Zero. It allows oncologists to confidently tell a patient you don't need chemo, safely sparing them from the hair loss, the neuropathy, and the immune suppression. It really is the pinnacle of precision medicine.
That is amazing. Now, there are a few highly specific clinical scenarios the text outlines that completely change the rulebook. The first is managing those BRCA mutations. We mentioned them earlier, but patients with a BRCA1 mutation face up to an 85% lifetime risk of breast cancer, plus a massive risk of ovarian cancer.
Which is exactly why bilateral risk-reducing mastectomies are offered, dropping that breast cancer risk by over 90%. And BRCA2 is unique because it's heavily linked to male breast cancer and prostate cancer.
That's a detail people often miss, right? Familial breast cancer impacts the men in the family, too.
It does. Now, male breast cancer is rare, making up less than 0.5% of cases. Because men have very little breast tissue, the tumor usually presents as a hard lump directly beneath the areola, and the standard of care is a straightforward mastectomy followed by tamoxifen.
Another scenario that is incredibly high stakes is diagnosing breast cancer in a pregnant patient. How does an oncologist balance saving the mother while protecting a developing fetus?
It requires rigid adherence to safety protocols. Ultrasound is the safest diagnostic tool. Surgery, surprisingly, is generally safe to perform during any trimester.
Really?
Yes, but the absolute hard line is chemotherapy during the first trimester. That is the period of organogenesis, when the fetus's organs are actively forming. Introducing cytotoxic drugs, then, is strictly contraindicated.
That makes sense.
However, once the patient reaches the second and third trimesters, certain chemotherapy regimens actually become safe to administer.
Wow, okay. And finally, the text addresses stage 3 advanced metastatic disease, where the cancer has permanently spread to the bones or other organs. The entire philosophy of care shifts here, doesn't it?
It does. The goal is no longer a surgical cure, it's palliation, managing the disease like a chronic illness to preserve the patient's quality of life. In those advanced stages, if the tumor is hormone positive, we heavily prefer endocrine therapies over chemotherapy simply because they are vastly less toxic for the patient to endure long term.
Right.
We utilize palliative radiation to shrink bone metastases, and we administer bisphosphonates to harden the skeleton against fractures.
But the text issues a massive clinical warning for recurrent disease. If a patient was treated for breast cancer 5 years ago and a new metastatic tumor pops up in their lung today, the doctor must perform a new biopsy. They cannot just assume it's the exact same cancer.
Never. Tumors evolve to survive. A cancer that originally relied heavily on estrogen antennas might recur years later, having mutated into a triple-negative tumor.
Whoa.
Yeah, so if the oncologist doesn't rebiopsy and simply restarts the old estrogen-blocking drugs, they're firing blanks. The new tumor will be completely immune.
So, synthesizing everything from the cellular mutations to the surgery and the mop-up phase, how does a doctor actually sit across from a patient and predict their future?
Well, the Bayesian lab text uses the Nottingham Prognostic Index, or the NPI. The NPI is a mathematical synthesis of the tumor's lethality. The formula is 0.2 multiplied by the tumor size in centimeters plus the lymph node score plus the grade score.
I stared at that formula for a while, trying to figure out why the tumor size is multiplied by zero point 0.2. Like,
Wow.
why mathematically shrink its importance?
Wow.
And it's because the biological aggressiveness, whether the cells look angry on the grade score and whether they've successfully invaded the lymph nodes, is vastly more lethal than the mere physical footprint of the tumor.
Precisely.
A massive, slow-growing, lazy tumor is significantly less dangerous than a tiny, highly aggressive tumor that has already figured out how to travel through the lymphatics.
The math reflects the biology.
Yep.
If the final MPI score is 2.4 or less, the prognosis is excellent. If it exceeds 5.4, the prognosis is very poor.
And the only surefire way to keep that MPI score low is to catch the tumor when it's microscopic. The standard screening protocol in the UK is a mammogram every 3 years for women between 50 and 70. But for those high-risk BRCA patients we discussed, standard mammograms just aren't sensitive enough.
No, they require an annual contrast-enhanced breast MRI to spot the cancer the exact moment it appears.
Yeah.
Early detection remains the ultimate weapon. It dictates whether a patient requires a brief day surgery or a years-long systemic battle.
We have unpacked a tremendous amount of science today, from the cumulative dangers of estrogen to the molecular antennas that drive cancer growth, and the ingenious ways surgeons use magnetic seeds to hunt down vanishing tumors. Thank you for joining us on this deep dive.
It's a great discussion.
But before we sign off, consider this. We started by discussing how breast cancer used to be entirely a surgeon's domain, just cutting away the anatomy. Today, with tools like Oncotype DX predicting genetic behavior and drugs like trastuzumab acting as cellular heat-seeking missiles, we can literally starve and reprogram tumors from the inside out.
It's a new world.
It really is. And if our systemic therapies continue to achieve these incredible complete responses where the tumor just melts away to nothing, well, are we rapidly approaching a future where breast cancer isn't treated with a scalpel at all? A future where the disease is entirely cured at the genetic level, rendering the surgical textbooks we rely on today completely obsolete. It's definitely something to mull over. Until next time.